Hello, everybody. It's an absolute pleasure to welcome you today. I'm Professor Faizel Osman, consultant cardiologist and electrophysiologist working here at the University Hospital Coventry in the United Kingdom. This is the Meet the Expert webinar, which is the conclusion of the webinar series on atrial fibrillation and hypertension, a risky couple, even more so with the family expands. We're very lucky today. I have Professor Thomas Mengden with us from Bad Nauheim in Germany, and I'll hand over to Thomas just to introduce himself. Thomas?
Yes. Hello, my name is Thomas Mengden. I'm working at the Krakow Clinic Bad Nauheim, and I'm head of the European Society of Hypertension Excellence Center there. So this already reflects my special interest in arterial hypertension, but at the same time, I'm non-invasive cardiologist working at a cardiac rehabilitation center in Bad Nauheim. So we have many patients with atrial fibrillation and with the comorbidity of arterial hypertension at the same time. So I have a scientific as well as a clinical experience in this topic. And I would like to start with my short Congress report of the recent European Society of Hypertension meeting in Milano in June this year, and the European Society of Cardiology meeting in the beautiful city of Amsterdam in September this year. So I will start with the new guidelines, which was the main topic of the Milan meeting of the European Society of Hypertension. The new guidelines are very long, 200 pages, more than 2,000 references, and no time to cite them all. So I will focus on two topics. One is the new guidelines concerning the blood pressure measurement, namely office blood pressure and ambulatory blood pressure measurement. And the second is the target blood pressure, which was also a focus of the meeting. So what is new for office blood pressure measurement? This is a figure from the guideline document. And this is applicable for home blood pressure measurement as well as office blood pressure measurement. And this is new in the new guidelines. We already used fully automatic osteometric upper arm devices for the home measurement, and this is now recommended also for the office blood pressure measurement, which is new in the guidelines. So for the office blood pressure measurement, 3 readings are advised with 1 minute interval between the readings, and the average of the second and third reading should be used for the office blood pressure measurement. So this is new. And then it's stated in the new guidelines that not unattended but attended office blood pressure measurement using an automated device should be used for the practical blood pressure measurement in clinical practice. We can discuss this later. What are the consequences of these recommendations? But this is the official recommendation. Next point concerns the ambulatory blood pressure monitoring. There was a meeting before the European Society. There was a working group, the working group which I'm also a member of, on blood pressure measurement of the European Society of Hypertension. And now new in the guidelines, you see in this box plot, is the recommended time interval between the readings of ABPM during the night. And the frequency of the readings was increased from 1 per hour to 3 per hour, which means that you now have triplicate measurement during 1 hour and 3 times higher frequency of measurements during the night. We can also discuss this later. What are the consequences for ambulatory blood pressure measurement, but also home blood pressure measurement for example, with the night view device. Then there was a was a discussion about the target blood pressure with antihypertensive therapy, and the target blood pressure was not changed in the new guidelines, although evidence from recent trials like the ACCORD trial, the SPRINT trial, and the STEP trial, recently published in the New England Journal of Medicine, suggest that intensive lowering of blood pressure with a systolic blood pressure below 120 millimeters mercury may be beneficial from prognostic point of view. This was shown also in post hoc analysis and meta-analysis of both ACCORD and SPRINT trial, and the achieved systolic blood pressure values are shown in the next line. They were between 119 and 125 millimeters mercury for these 3 trials for the intensive blood pressuring lowering group, and the respective values for the conventional group were 134 to 135 millimeters mercury. And results of the optimal trial are awaited. Recruitment is fully completed. It's also a target blood pressure value study with diabetic hypertensive patients, comparing a intensive lowering below 120 millimeters mercury versus a conventional blood pressure lowering below 140 millimeters mercury. Results will be awaited in 2 years' time. So this were the main messages from European Society of Hypertension meeting. I will continue with the European Society of Cardiology meeting in Amsterdam, and a focus was on digital devices to detect and manage atrial fibrillation. And there were many sessions with the topic of screening for atrial fibrillations. And this will be the focus of my next slides. In the beginning, I would like to mention that with the intensive screening in high-risk groups, you have a high prevalence of detecting atrial fibrillation, and the question is which AF burden, atrial fibrillation, is prognostic for patients. So it was discussed that with continuous screening over 14 days, for example, a AFib episode over 6 minutes may be prognostically significant with a stroke risk of over 2% per year. So we have many devices. I won't go into detail for the digital devices for the screening and also for symptomatic patients. Mainly they can be divided in PPG-based devices and ECG-based devices. PPG-based devices are based on photoplethysmography, so it's a pulse recording which gives an indirect hint of atrial fibrillation. But if you have suspicion of atrial fibrillation with PPG-based devices, it should be confirmed with an ECG-based device. In this section, we have then handheld devices, smartwatch ECG, patch ECG, and lead-based ECG devices. We can later discuss which role the OMRON Complete device plays in this scenario. It's an ECG-based device with one-channel recording and a handheld technology. So I will flip through the symptomatic patients and continue with the screening for asymptomatic patients. So what are the patients which may be suitable for screening? There are several markers which can help us for the choice of screening mode to take into account. These are listed on the left side of the table. There is obviously age, which is a important point for screening. The higher the age, the more the prevalence of atrial fibrillations. There are comorbidities, and I think especially hypertensive patients, they have often many comorbidities like sleep apnea or obesity or diabetes or heart failure. We have biomarkers. We have also the question of screening opportunities like systematic screening or opportunistic screening. And it was discussed at the conference that with opportunistic screening, you won't get enough patients. The screening is not relevant, so one should use systematic screening. And one point is also the digital competence of the patient, the literacy. Can you cope with a special device? And then we have, as already mentioned, the PPG and ECG-based devices. So for the screening strategies, we have single-time screening, we have intermittent screening, we have continuous screening, and we have continuous long-term screening with the several devices listed in the figures. You can use blood pressure monitors or single-lead ECGs for single-time screenings. For the intermittent screening, you can also use blood pressure monitor, which may be equipped with a supplementary one-lead ECG. Then for the continuous screening, we have the ECG patch from 7 to 28 days, and we have continuous long-term screening with the implantable loop recorders. So what is the prevalence of atrial fibrillation with these different screening methods? So with single point screenings, for example, using a blood pressure monitoring, we have a prevalence of 1.7%. With the intermittent screening methods, with a blood pressure monitor or PPG method, with measurements between 1 and 4 per day, we have up to 7% prevalence of atrial fibrillation. With continuous screening, for example, with ECG patch method over 14 or 28 days, we have a prevalence up to 16%, and with continuous long-term, we have prevalences up to 35%. However, what was new for me, and which is very important, the stroke risk decreases with increasing intensity of screening. So we may get more patients where we can detect asymptomatic atrial fibrillation, but obviously the stroke risk decreases with the increasing intensity of the screening. So the question is, would we need a special CHET score for the intensive screening, or can we use the normal CHET score for the opportunistic screening? I think this is an open question, and maybe the atrial fibrillation burden, which I already mentioned in the beginning, may help us in this setting. So, okay, so I will give you the summary later. Thanks you for your attention.
Thank you very much indeed, Thomas. Excellent talk there. Thank you very much for that. I just should mention to our audience that we were supposed to have Professor Angela Mas from Netherlands joining us today. Sadly, she was unable to join and sends her apologies. So, Thomas, thank you for that excellent talk. For just also remind the viewers that if you have any questions, please do put them in the chat, and we can discuss them and hear what Thomas has to say with the comments that you have. So please feel free to add your comments on and ask any questions that you wish. While that's happening, I'm going to just start off, Thomas, by asking you a couple of questions. In terms of the guidelines and what you've discussed, what do you feel are the most important messages that have come out from these guidelines? What are if I said to you, okay, you have to give me 1 or 2 key messages to go home with, in your opinion, what are the most important 1, 2, 3 highlight points that you would take away?
Yes, you can see the summary of the ASH guidelines, and I think the most important is that for the attended office blood pressure measurement, now purely automatic osteometric devices with the possibility of triplicate readings are preferred and recommended. This is very new, and we would have to take a look which devices can be used. And at that point, I would also already like to address the the problem that if you have a fully automatic professional device for office blood pressure measurement, which is able of taking triplicate readings with 1 minute pause between the readings and averaging the readings, I think this would be similar to an unattended reading, because I cannot imagine that the physician or the physician assistant will wait 5 minutes at the side of the patients and take these unattended office blood pressure measurements. So I think the most likely scenario is that you would start the reading and the professional device would go on by itself, and you would return after 4 or 5 minutes and take the results. So I think with the recommendation of these fully automatic osteometric devices for office blood pressure measurement, it's more an unattended than an attended scenario. I think this is very important. And for home blood pressure measurement, there's a preference to use this method for the follow-up during therapeutic intervention. I think is very important. The guidelines committee was a little bit too conservative and hesitant to name whole blood pressure measurement and ambulatory blood pressure measurement as the method of first choice for both diagnosis and target blood pressure measurement. And I think the office blood measurement has very many shortcomings, and I would have wished that the out-of-office blood pressure measurement like home and ABPM would be more preferred than actually stated in the guidelines. Then the increase of the night measurements is a very important topic. So we have an increase for free measurements during the night per hour, and this raises the question on patient comfort. And we know from recent studies that with 10 or 20 or even 24 readings during the night, there's a significant disturbance of the sleep, and this disturbance may raise blood pressure artificially. So the question is, so we know that the night values are very, very important for prognostic aspects, but with increasing the frequency, we will introduce much more disturbance for the patient and decrease the patient comfort and potentially increase the nighttime readings. And the question is also, when we do not use an ABPM device, but instead a home device, which takes 3 readings per night, the period of screening would have to be increased to at least 6 or 7 days to generate a comparable number of readings like the ABPM with 3 readings per hour. So I think this is a very important change, and which also affects the home blood pressure night readings. So, and at the end, concerning the screening, I think blood pressure devices for office blood pressure measurement in hypertensive patients may be useful for single point and intermittent screening, especially in high-risk patients like the elderly hypertensive patients with comorbidities. And these would be my main messages.
Okay, thank you. Thank you very much indeed for that, Thomas. If I can ask you another question, in terms of cuff size, what are your thoughts on cuff size? We know that obviously having the incorrect cuff size can impact the blood pressure reading. What are your thoughts, particularly given the fact that we have a lot of devices? You mentioned the OMRON Complete, which we can talk about, is a complete sort of a blood pressure and a single channel ECG recording. What are your thoughts on cuff size, and should devices offer a variety of cuff sizes, and what are your thoughts on that and an impact on blood pressure readings?
Yeah, okay, cuff size is essentially, we know that, but I would estimate that in clinical practice, cuff size is not taken into account. I think most my colleagues, they would only use one cuff size, which is the medium cuff size, but with the increase of obesity, many patients have upper arm circumferences which are much higher than the cuff size with the M size covers. So it's 42 centimeters, which is the limit for the medium cuff size. So if you use a medium cuff size for a obese patient with higher arm circumferences, you get a high overestimation of blood pressure. So this introduces wrong estimation of the real blood pressure level. So one solution might be universal cuffs which fit for medium and bigger arms. And for example, in Germany, we have had recently a discussion with manufacturers of home devices. Also, OMRON company attended this meeting. And I found that most of the German companies who offer home blood pressure devices, they have already universal cuffs. So it seems in Germany that the universal cuff is now the normal scenario compared, let's say, the time 5 to 10 years ago. This was not the normal scenario. We had these different cuff sizes, and we had to change the cuffs depending on the patients. And often the patients used the wrong cuff size. But I think with the universal cuff, this problem might be solved.
Great, thank you. Thank you very much for that. And again, I just remind our audience, if you have any questions, please do put them up on the chat, and we can try and discuss them and take them further. Just one more from me, Thomas, before I hand over to you about comorbidities and risk factors. In terms of changes in guidelines, you very nicely highlighted in your presentation. Again, what do you feel are the critical changes that have occurred in the guidelines in ESH and ESC? I know you touched a lot on attended versus unattended measurements in clinical practice, and that's how important is that, and what are your thoughts on that?
So it's a very important topic, and I think intuitively we would prefer unattended readings because it doesn't introduce the white coat effect, which is higher when physicians are taking the readings compared to physician assistants. But we have learned from previous studies, the Canadians were very active in this field. Martin Myers has published quite a lot of studies on the automated office blood pressure readings. Automated office blood pressure readings is the unattended method of readings. And when you take all the studies together, you come up to the conclusion that the automated office blood pressure readings or the unattended readings, they have lower normal values. So our limit for arterial hypertension, which is for systolic blood pressure 140, it would have to be lowered to 135 millimeters mercury, because the white coat effect is away. So, but this would put us, we would face the problem with new normal values like 135 for the automated blood pressure measurement. We don't have prognostic data for unattended automated office blood pressure measurement. And I think with this in mind, the European Society of Hypertension Guideline Committees stated explicitly that an attended office blood pressure measurement should be taken because otherwise they would have had to change the limits of normalcy. I think it's a good thing that the white coat effect is eliminated, but it confronts you with a second problem of normal values and lacking prognostic data. And I have already mentioned the SPRINT trial where unattended office blood pressure readings were used. And there was much discussion the last 4 or 5 years since publication of SPRINT. At each congress, the SPRINT trial with the unusual way of measuring office blood pressure is discussed, and from different point of views. And I may repeat the main results of SPRINT, which compared intensive blood pressure lowering versus conventional blood pressure lowering. And by surprise, in the SPRINT, it was found in an ABPM sub-analysis that the daytime ABPM readings, which are normally lower than office blood pressure, were higher than the automated unattended office blood pressure readings. So quite a confusion. Why? No? Some experts, they discussed this observation that the office blood pressure measurement were paradoxically higher than the ABPM readings. And they explained it by the special method of unattended repeated office blood pressure measurement. This is one explanation. My personal explanation for the SPRINT trial is a little bit different. In the SPRINT trial, it was not specified at which time the office blood pressure should be taken. So it was not stated that the trough measurement before intake of morning medication should be used. So it was to the choice of the investigator at which time he would measure the office blood pressure. So this is a black box. We don't know. But I would suppose, I have made many trials myself, that normally in a trial, and also you may have observed this, the patient comes in, let's say at 10 in the morning or 11 in the morning or 9 in the morning. And I think in SPRINT, most patients had already taken at that time their morning medication. And so my personal explanation for these paradoxically observed correlation between office and ABPM readings, it is the suspicion that the office blood pressure was not taken trough. That means before morning intake, but after 3, 4, 5 hours after the morning intake. And that may have resulted in the low unattended office blood pressure measure readings. So this is a very important topic. It appeared to us that with the automated devices and the unattended readings, we would have achieved an advantage. Obviously, we have more accurate blood pressure readings because we have 3 readings which are very stable when we take the average, but we have to take into account that normal values may be lower. My personal approach is that I use a professional office device which takes 3 readings with a 1-minute pause between the readings, and I leave the patient alone and I take this as the office blood pressure. I think it's better than the attended readings, and I think the attended reading, it will not be practiced because, for example, in Germany, physicians are very busy. They have no time to sit 5 minutes aside the patient, and neither the physician assistant, she has no time to make a 5 or 6 minutes attended office reading. So I think the recommendation from the guideline committee, it's a little bit academic, I would say.
Yeah, no, thank you, Thomas. No, that's a very, very fair point, and you raised some very, very important points about the trial, the SPRINT trial, particularly about how and when the recordings are taken, of course, in the clinic. Very, very good points. We have one question from Lothar, who online. So the question is, with regards to blood pressure monitor designs, it might be a good idea to find alternatives to the Velcro of the measuring cuff. This tends to lose its grip, which it does, of course, over time, and the readings may not be accurate. Are there any modifications of this that you're aware of existing currently?
Okay, so the material of the cuff.
The Velcro. I think the question is around the Velcro design that's used to wrap around the arm. I have to confess,
okay.
All the blood pressure cuffs I've come across have Velcro when you put it around the arm.
Yeah. I think,
but the point being made is that
yes, these Velcros are used for home blood pressure readings. Yeah, and what was the question?
It was The question was around these Velcros lose their grip over time, so they may become more inaccurate in terms of the blood pressure reading. So are there any modifications that you or I aware of that can help to improve the accuracy available out there at the moment, or is Velcro the only one that is in use?
I see. Okay, I must confess I'm not aware of it, but I think the problem with the that they lose their grips, it applies more to the situation when you use home blood pressure monitors in a clinic or rehabilitation setting, because then you have much more readings than an individual patient would take for personal use. So I think the loss of grip for the home application, one monitor, one patient, I wouldn't see a problem, perhaps after 10 or 15 years. But let's say within a range of 5 years, I would not see a problem. Then the next device comes, which obviously might be much better than the recent one. But I think that the problem with the grip, I observed this in the clinic where home blood pressure monitors designed for individual use are used for 20 patients. And then they lose their grip.
Yeah, no, I think that's a very, very fair point. And I guess the key thing is that when devices are being used, and this is generally fair of any investigation we're doing, that they're maintained, that they're serviced properly. If the cuff looks like it's falling apart or that's replaced and serviced, so that when we do hand it to multiple patients, at least we're getting accurate information. You only get the accuracy from having equipment that is working properly. So a good question from one of our viewers there. Okay, so shall I hand over to you now, Thomas? I think we were going to talk about hypertension and atrial fibrillation as well as the next section, so and potential comorbidities. I think you had a few questions that you were going to put forward to me with regard to the talk that I gave earlier in the series.
Yes, okay. So from a clinical point of view, we have this connection between atrial fibrillation and arterial hypertension. And we know that we have structural changes in the heart, which predispose for atrial fibrillation, hypertensive patients. And I would like to ask you to specify which comorbidities predispose for asymptomatic or symptomatic atrial fibrillation, and show us the anatomical and remodeling changes of the heart which predispose for atrial fibrillation.
Thank you, Thomas. Yeah, no, you're absolutely right. So I think the link between hypertension and atrial fibrillation is very, very strong. There's a very strong correlation between the two conditions, and this is why when we look at various guidelines, they talk about a screening and looking for one or the other if you have that one condition. And as you very nicely pointed out, that one condition can lead to the other condition. So the two are strongly related. And when you remember that hypertension affects 1 billion people globally, and it's a very, very common condition. And we know that that is associated with negative cardiovascular outcomes. We know atrial fibrillation, the commonest arrhythmia out there, and that both those conditions also do predispose to stroke. And when you have both of those conditions coexisting, you almost double your risk of stroke that you would otherwise have. So again, very, very important to recognize that combination of hypertension and AF is very, very important. And thinking purely from a physiological perspective, if there is elevation in blood pressure, systolic, diastolic, we know that can lead to changes in the heart. We often talk about left ventricular hypertrophy, which may be seen on cardiac imaging, on echo, cardiac MRI. But of course, it also causes dilatation, perhaps of the chambers and certainly of the atria. And that atrial stretch, that mechanical stretching of the myocardium itself can lead to changes of the electrical properties. So you have electrical remodeling that can take place. We know that there is a mechanical remodeling that takes place at the same time. And this combination obviously then increases the risk of atrial fibrillation that can happen. And so very, very important that if patients have hypertension, for example, not known to have AF, but we know that these patients are at risk of developing atrial fibrillation, fibrillation purely when you think about the physiological basis of it. And so treatment of that hypertension becomes even more important. But of course, also importantly linked to that is to ensure that we are looking for atrial fibrillation. We know that AF can occur in a significant number of people and they're completely asymptomatic. They don't even realize they have it. And so if you don't know you've got a certain condition, you can be at risk of the negative effects of that. And if you're hypertensive, we know you can be at slightly higher risk. And then the question, of course, around screening, etc., comes into play. So really, in conclusion, I think hypertension and AF are both common. You touched a little bit on risk factors and what the important risk factors are, and actually these are increasingly becoming recognized. And certainly in the webinar, when I talked about risk factors, I highlighted some of the key risk factors that are important in that. And I think, again, the ESC have produced some very, very nice guidelines on atrial fibrillation management, as well as hypertension, that talk about the key risk factors. And there are certain risk factors that we can't do much about. Age, for example, we're all aging. There's no cure for aging. Male gender, of course, our genetics is something that we can't really do anything about. So these can predispose us. However, there are many, many things that we can do something about. And they include hypertension, good blood pressure control, good diabetes control if patients have diabetes, weight and obesity. Again, you touched very nicely in your talk the link between hypertension, obesity, and of course in the Western world it's becoming an epidemic. The same problems exist in atrial fibrillation as well. We know that if you're overweight, you're at higher risk of developing AF, and also treating the AF and keeping you in sinus rhythm becomes more difficult the more overweight someone is. So that's also another very important risk factor as well. And then you have other risk factors that also go along with atrial fibrillation. Physical inactivity, hyperlipidemia also has been linked, and increasingly we're now seeing conditions like sleep apnea also being linked as well. So people with obstructive sleep apnea, where they're getting hypoxia, can actually in itself predispose. And we have a study ongoing at the moment called the Oscar trial, which we've just finished recruiting to, looking at patients with sleep apnea in whom we are implanting an injectable loop recorder. And these are patients not known to have atrial fibrillation, and we're wanting to see what is the true rate of pickup of atrial fibrillation in these patients. And I think we'll be surprised with the findings using devices like the ILR, which obviously has a much greater specificity. So I think tackling all of these, and then of course you have lifestyle factors, which I haven't even touched on, smoking, and the big one is alcohol intake, and convincing our patients and all of us really that alcohol is something you have to be very careful with. It's a toxin, and it does increase the risk of atrial fibrillation and other conditions. So I think it's important that we highlight this to our patients and ensure that we have good control of those risk factors that we know lead to negative outcomes in people with hypertension and atrial fibrillation.
Yes, thank you for your overview. And I think very important is our lifestyle measures. There was one session at the SH meeting which only covered lifestyle measures, and you mentioned them, like obesity, like alcohol, treatment of sleep-related breathing disorders. So I would like to ask you, what do you think about the J-curve relationship between exercise and atrial fibrillation? There was discussion how much sport might be too much to predispose to atrial fibrillation. So what is your personal opinion? What is the cut-off value for the hours of sports per week, where you will see the J-curve?
Again, another excellent question, Thomas, and you're quite right. You know, this relationship between exercise and occurrence of atrial fibrillation, and not just atrial fibrillation. It's interesting. We obviously come across patients, athletes' hearts, people who do a lot of exercise, do triathlons, do a lot of cycling, do a lot of running, a lot of swimming. I see almost every week I see patients who are ultra fit, very, very fit, do a lot of exercise, and they've developed atrial fibrillation at a relatively young age, in their 40s or their 50s. Their resting heart rates, of course, are usually very, very low in their 40s, and that's because they're ultra fit. They have a very high vagal tone, and so it's something you would expect. But you're right. These there seems to be a predisposition to developing these arrhythmias, particularly atrial fibrillation. What I tend to advise my patients is that, look, moderate levels of exercise several times a week, is actually quite important and is associated with lowering cardiovascular risk, and also helps in terms of maintaining body mass index, weight, etc., and is very, very important. Once you start getting into very, very high level extreme sports where you really are doing lots of running every single day or lots of cycling hours on end, and putting the body through quite a bit of stress, usually in young people, you can adapt, and the heart changes, and we see that on echoes or cardiac MRIs that we might do, where the LV has dilated, there may be some hypertrophy, and we're not quite sure, is this normal, abnormal, pathological? Well, my feeling is that you shouldn't really have hypertrophy or dilatation in a normal heart, and clearly this is the body's response to the excessive levels of exercise that are being done. And what often I do tell my patients, particularly the younger ones who are doing excessive amounts of exercise, and that usually involves lots and lots of running on a daily basis, lots and lots of swimming, and it can be difficult. People can get into routines and actually enjoy it. They release endorphins, and it's enjoyable. But sometimes you have to ask people just to cut back a little bit because of this J relationship that you mentioned, and particularly those that are young who come in and they have atrial fibrillation and not expecting it. And it is very curious when we look at the differences between the atria and the ventricles. Normally high vagal tone, all of the research studies looking at the basic science and clinical science suggesting that high vagal tone is actually protective in the ventricles, so seems to reduce the risk of ventricular arrhythmias. But interestingly, maybe the opposite may be the case in the atria, where actually when you have a very high vagal tone, we know that very often AF can be triggered by bradycardic episodes in the night, where patients go very bradycardic, and that triggers off a run of atrial salvos, and AF is then triggered. And so maybe high vagal tone may not be so great for the atria, perhaps. And it's interesting, when we treat atrial fibrillation with ablation, we ablate around the pulmonary veins where the ganglionic plexi are, where the parasympathetic input comes in. And again, a lot of evidence and research suggesting that actually ablating those areas may improve the outcome of AF ablation. So is there some impact of affecting cardiac autonomic control and actually dampening down vagal input to the heart, being beneficial in terms of preventing AF? So these are all questions I think that are yet to be answered. But again, exercise is something that has a huge impact on cardiac autonomic tone. So it's a balance. You're right. There is this J-curve relationship. And I tell my patients, look, moderate, regular exercise is very important. And I would argue that certainly at my age, walking is probably the best form of exercise because you can do it for longer without impacting your joints, which becomes important as we all get older, and you can go for longer. But excessive exercise, lots of running, lots of swimming, lots of cycling, for example, running triathlons on a regular basis may not be as good for you, I think.
Okay. Yes, thank you. Very interesting topic. And I think more and more patients address us with this topic, because now even elderly patients, they start with 50 or 60 preparing a marathon.
Yes.
And
True.
We are facing more and more patients like this. But this would bring me to a question in younger athletes. If you detect by screening or by symptoms atrial fibrillation, do they have a increased risk for stroke? They have an increased risk for atrial fibrillation, but what about the risk of stroke in these athletes?
Yeah, again, a very, very good question. And again, I think what we tend to do is we diagnose atrial fibrillation if we see it on an ECG or a single channel recording, which is what the ESC guidelines advocate, of 30 seconds or more that's been confirmed by a physician. We treat it like any other atrial fibrillation. So we look to the CHA2DS2-VASc score. And if the CHA2DS2-VASc score indicates that they need anticoagulation, we start them on anticoagulation. If their CHA2DS2-VASc score is 0 or it's 1 because they're female, then they don't need anticoagulation. But again, there's a lot of debate happening. So a recent study, the NOAA AF trial that was published, looking at atrial high rates in people with devices. And these are episodes, precursors of atrial fibrillation, or may even be atrial fibrillations that are occurring. And patients were randomized to oral anticoagulation with a NOAC versus standard care. And people were presuming, these were people with high risk, high transvascular risk, and people were presuming that actually that there would be clear benefit for commencing anticoagulation. But to everyone's surprise, actually there wasn't a benefit, as you're aware, Thomas. And this was presented at the ESC, in fact, this year, just a few weeks ago. And in fact, the study was stopped early because of higher rates of bleeding in the intervention arm. Now, there was a small use of aspirin in the study in both arms, and there is an American study called Artesia, which I think is due to report in due course, which is looking at a similar problem, but comparing apixaban versus aspirin. And I have some reservations about the aspirin arm in that study. We know aspirin doesn't work anyway in atrial fibrillation as stroke prevention. But this study is going to compare apixaban versus aspirin. So we'll wait and see what the results of that study show. But there is increasingly debate about how long AF should be there for if you have these atrial high rates, which we often do see in young athletes. What is the significance of that? And again, the ESC have produced a very nice table which talks about the duration of the event, the risk profile, the CHADS VAS score of the patient, and trying to come to some consensus about a decision about whether to treat with an anticoagulation or not. But I think NOAA AF has certainly perhaps muddied the water, is maybe maybe not the right way, but it has just added a level of confusion because it wasn't quite what we expected from that study. But that's why we do randomized controlled trials. That's exactly the reason why we do that.
From your comments, I take that for athletes, we have no prognostic data whether oral anticoagulation is of benefit or not.
No, not from my reading. There is no evidence that taking oral anticoagulations simply because your athlete has any beneficial effects. And if anything, intuitively, my feeling is it would probably lead to increased bleeding. And again, athletes tend to be more physical. They're doing more running. They're doing more things that are likely to cause them to knock their arm, their leg, the feet. So you can imagine if they're on anticoagulation, this might potentially cause more bleeding.
Thank you. I think there is a question from the audience.
Yeah.
I can't see it.
Okay, so I'll have a look. So yes, there's a question. So Arshna is saying, what is your experience with patients monitoring ECG with smartwatches and wearables at home? Does this increase your workload? Does it lead to increased early detection of atrial fibrillation? Again, another excellent question. So if I tackle that one, Thomas. So we are increasingly seeing patients and not just patients, colleagues and friends and family with smartwatches and wearable devices, and these will continue to rise, I've no doubt. And this does increase the workload. So I have patients that regularly send me emails or to my secretary with tracings to look at. Now, I think we are going to have to accept that this is going to happen, and leaving patients with these devices without any backup, I don't think is sensible. And even the ESC guidelines recognize that in order to make a diagnosis of atrial fibrillation, when you have this, they talk about 30 seconds or more on a single channel recording. But that does need verification from a clinician, from someone who's experienced. And the most comments I get from patients is where there is a recording, there's a tracing, it's specified as being unknown, indeterminate, could be normal, but it may not be, and there's a lot of artifact. And this is where you need someone who's experienced at looking at these things to give some guidance to the patients. Will it lead to increased workload? Undoubtedly, it will. And I think this is where our specialist nurses, for example, we have excellent arrhythmia nurses, and they really are the lifeline of our service. They're the interlink between patients and us. They become very helpful in terms of helping in diagnosis of these conditions with these new wearable devices that we're going to see. And increasingly, of course, we have devices like the OMRON Complete that have the single channel recording, the AliveCore single channel recording, and the blood pressure monitor. So we're getting hemodynamic and rhythm management both at the same time. So I think that this is the way the future, this is the way things are going, and I think our workload will definitely increase.
Yes, I can share the same experience with the workload. And you mentioned that with the smart watch devices, we have many artifacts, obviously.
Yes.
And these are not they are commercially available, but it's indicated that they are for entertainment purposes only. So, and I think Apple doesn't want have a they don't want to produce a medical device. Obviously, it's for entertainment purposes only, and this shows the problem. And my experience is when comparing, and you mentioned that, comparing the readings with smartwatches with the OMRON Complete device, you have a much better resolution and a much better ECG recordings, because it's standardized, the patient is sitting, many artifacts are eliminated. You still need the readings by a physician, that is obvious, but the quality of ECG readings, one channel is much better than with the smart watches. What is your experience?
Yeah, no, you're right. The quality of the reading is very important, and single channel recordings, can be very helpful. It's about educating patients of taking good quality recordings. So smartwatches, in my experience, can be quite tricky and fiddly. There are other devices out there as well, where we can actually have, for example, the LifeCore has a single channel and a 6-channel recording now, that you place your thumbs either side and place the other electrode onto a knee, or the left leg, or the left knee, and that can give you 6-channel recordings. The key is minimizing the artifact. So whatever device is being used, single channel or 6-channel, minimizing the artifact as much as possible. And I think these devices are improving. They are getting better. And there are also algorithms and AI that now is able to automatically detect atrial fibrillation, bradycardia, tachycardia, normal sinus rhythm. So if the bulk of those can be binned into one or the other, and the patient can get the answer immediately from an algorithm, great. I think that will help to reduce our workload. So it's all about picking up those important ones where they have a tachycardia or a significant bradycardia that needs attention. If it's normal heart rhythm, the device can say, no, normal sinus rhythm, you don't need to worry. And the indeterminate ones can then be sent over to clinicians to have a look at.
So what is your feeling about the influence of artificial intelligence? Will it improve the diagnostics of smartwatches or single point screenings?
I think, again, another good question. I think it will. I think it will in time. We're seeing artificial intelligence coming into play in many arenas within medicine. Our imaging colleagues, MRIs, our pathology colleagues even use it now for slides at our hospital. They're using AI algorithms to automatically scan slides, for example, looking at cellular structure. And so, these softwares, these computer algorithms are very helpful. And with the advent of artificial intelligence, machine learning, if you are able to program a system to be, and again, I'm not an expert in artificial intelligence, but there are experts who I've spoken with who assure me that actually in time that these systems can become very reliable. And so there's no doubt with time, with more learning and more samples that these systems see, the better they become at predicting what they're looking at, and may in fact pick up things that the human eye may miss. So that's the other big advantage as well. So I think in time, in 5, 10 years from now, AI I think will be quite widespread in medicine.
Yes, I attended one interesting session on Sunday afternoon where Professor Paul Friedman from Mayo Clinic, he presented, have you heard, maybe you have heard the talk, results from a project using artificial intelligence in a FIB screening, and he did a retrospective analysis of patients who were initially in sinus rhythm, and one half developed atrial fibrillation within several years, the others not. And they did an analysis with artificial intelligence for the ECGs in the sinus rhythm. And AI was very good in predicting AFib from the initial ECG in sinus rhythm, and the physician could not detect a difference. And I asked Professor Friedman what were the differences between the ECGs in sinus rhythm, and he told me that only the artificial intelligence itself knew.
Yeah, That's right. No, I recall seeing that paper as well. So it's amazing how we might potentially be able to pick up certain features on a baseline ECG that we as humans can't really tell, but a computer system, an AI algorithm can pick up and predict, yes, looking at the ECG, you in 5, 10, 15 years from now may end up getting atrial fibrillation. And that's very powerful information to have, because then you can prepare yourself and then you can really tackle those risk factors that we know can lead to atrial fibrillation. So I think that is very, very, very important. I think we have a few other questions as well. If I can just go to those, Thomas. I know you don't have sight of those. So Yaneka is asking, hi Thomas and Faizel, thank you for the information provided. Question from my side, which kind of patient would you recommend to monitor him or herself, and how often? Also, when looking at prevention of hypertension and AFib, are there any specific characteristics such as age, gender, other diseases where you would recommend preventative measures?
So in healthy?
So I think this is referring to healthy people. I think so. These are people where you're monitoring, and it's talking about prevention of hypertension and atrial fibrillation, and characteristics that you might look out for specifically, and things you might target.
Yes, prevention of hypertension is seldomly touched, I must commit. But obviously we have these categories of arterial blood pressure, and we have the category of elevated blood pressure, but we also have the category of high normal blood pressure. And if you would ask me what would be preventive strategy, I would focus on the group of you can't say patients, people who have a high normal blood pressure, which is for the office reading 130 to 140. So officially, they have not exceeded the limit of normalcy for the office readings of 140. But I think this would be a very interesting group to focus preventive measurements like salt restriction or regular exercise or treatment of obesity or sleep-related disturbances, high normal blood pressure values.
Yeah, no, absolutely. That's very helpful. And in terms of atrial fibrillation, very, very similar. Increasing age, people with a history of comorbidities such as hypertension, diabetes, particularly hypertension. These are the ones that all the guidelines tend to target in terms of screening and looking out for whether somebody's likely to develop AF. So we have a quick comment about the webinar, the series webinar. So just to remind our viewers that yes, the OMRON Academy has the webinar series, a series of about 7 talks that are on there. So please do go and visit that site. The address has been put up on the chat, so just please click on those, have a look at those, and they are available. Whether there is CPD available for those, the OMRON team may be able to answer that. I don't quite know the answer to that, but they are certainly there to view, and so I would certainly encourage everyone to make an effort to go and have a look at those. I'm aware now we're at 5 o'clock. Thomas, do you have any final words before I close?
Yes, I have a final word. I attended both congresses, the ESH meeting in Milano in June and the European Society of Cardiology meeting in Amsterdam. And I observed that there's still a focus of the hypertension meetings on hypertension, so AFib. There were very, very few sessions on atrial fibrillation on the ESH meeting in June. And on the other hand, if you take a look at the Congress in Amsterdam was much bigger than the one in Milano, but there the focus in terms of atrial fibrillation, it was on atrial fibrillation, but not connected to arterial hypertension. So I think what not only for the congresses, but also for our colleagues, physicians, internal medicines, cardiologists, GPs, I think we have to increase the awareness that the two conditions are closely connected. And up to now, I have the feeling that the cardiologists think about AFib, but not arterial hypertension, and vice versa. And I think using combined monitors like the OMRON Complete is a good chance. And several years ago, 10, 15 years ago, I used combined measurements for ABPM ECG readings. There are 2 monitors worldwide which offers such readings. And I think a good idea to start with would be the use of the combined monitors for office readings and also the use of combined monitors for ABPM, combining blood pressure measurement and ECG, and such increasing the awareness that both conditions are closely related.
Yeah, no, I would absolutely reiterate that message, Thomas. You're absolutely right. We sometimes do end up working in silos, and you're absolutely right. In the EP world, we look at AF and we try and concentrate on that, but hypertension is a huge part of it. If you don't control the blood pressure, you're not going to treat the AF. It doesn't matter what you do. You can do as many ablations as you want. If the blood pressure is poorly controlled, the AF will keep coming back. So I would absolutely agree with you and reiterate the message you've just provided. Just to answer the earlier question about CME, unfortunately, there are no CME points with this webinar. Okay, so thank you very much indeed to Professor Thomas Mengden for this excellent webinar today. My thanks to all of our viewers out there. And once again, I would strongly encourage you to go to the OMRON Academy online and check out the webinar series, and please do log on to those. My thanks to all of you for participating and for joining us, and wishing you all a very happy afternoon, and look forward to seeing you the next time. Thank you very much indeed. Bye-bye.
Okay, thank you. Goodbye.
Bye-bye.